The discussion has been quite good, and it was impressive that it was not biased in a way. So I found that it is very important that we were able to share and discuss the way clinicians are supposed to. So that's really eye opener and good for students and junior colleagues like us. So, disclaimer: these slides are provided by Novartis, and we'll start with the case study. So, a 63-year-old woman presented with lump in her breast. The patient had a 2 centimeter breast mass, lymph nodes. She was referred to a medical oncologist. Core biopsy showed hormone receptor positive, HER2 negative breast cancer. However, CT showed two liver lesions. MRI brain was negative for mets, and she is a de novo mesh patient. She has not received any treatment previously. So, what's the goal of treatment for patients? It remains very similar for any patient in advanced cancers. We try to improve the survival. We try to reduce the toxicities to the treatment. We want to provide good, fast symptomatic relief to the patient. If we are able to provide all these things, it will automatically lead to improved quality of life. So, quality of life seems to be the most important goal for most of the patients. However, sometimes some patients will ask to prolong the survival at the cost of increased toxicity as well. So it differs from patient to patient, but in general, quality of life is really, really very important for all our patients. So these management algorithms have been discussed. I will not repeat these things. So hormonal therapy is now the mainstay for treatment for hormone receptor HER2 negative advanced or metastatic breast cancer. We all are aware of the same. And we have now know that CDK4/6 inhibitors play a very, very important role in the management. So what's difference between CDK4 and CDK6? Most of the drugs seem to affect both, but is there any difference? Yes, there seems to be some difference. First, let's talk about CDK4. CDK4 plays a key role in the tumorigenesis and the proliferation, and it is abrogated 8 times more than CDK6 in breast cancer cell lines. So it appears that CDK4 is more important target than CDK6. That needs to be understood, and this is based on the preclinical and well-conducted mouse model studies. So inhibition of CDK4 has been shown to block the ability of breast cancer cells to form tumors, and available drugs penetrate tumor cells CDK4. So this is the chart which we are learning from the time of our DM and any time of our starting of the oncology training. So G1 as G2M phase. So what happens? The pathways, including the estrogen signaling pathway, stimulate the cyclin D production, and binding of cyclin D activates CDK4/6, which is an important player in the pathway, and it will lead to progression in the terms of tumorigenesis, and will lead to proliferation of the cells who are estrogen receptor positive. Selectively inhibiting CDK4/6 will cause cell cycle to arrest in the G1 phase, resulting in reduced cell viability and tumor shrinkage. And how we choose a CDK4/6 inhibitor: stage of the breast cancer, treatment history, relapse rate of the disease, premenopausal or postmenopausal, drug-induced adverse effects. In the previous discussions, we have seen the adverse effects are the key to decide the treatment. Patient and treatment team preference for the medication. Some might prefer to taking regular medications, while some, if patient is asked, they might say they might prefer 3 week on 1 week off schedule, but this might or might not be the scenario. Health insurance: sometimes some insurance will prefer one of the available 3 options, and this will help in decision making. So the investigations into CDK4/6 with combination of endocrine, we have clearly seen that these are able to provide significant improvement in progression-free survival, overall response rate, and clinical benefit rate as against endocrine therapy alone. So these are the trials which are led to approval of the CDK4/6. The Palomar 2, Mona Lisa 2 for ribociclib, Monarch 3 for abemaciclib, Mona Lisa 3 for ribociclib in first and second line in combination with fulvestrant, Mona Lisa 7 in premenopausal patients in combination with tamoxifen, letrozole, or anastrozole. So we have seen a lot of data. So do all CDK4/6 inhibitors result in improvement in the survival, overall survival? So this is the data what we see for ribociclib. We have the data of improvement in overall survival, which is significant statistically in all the scenarios. Whether it is postmenopausal patient combination with aromatase inhibitor, whether it is postmenopausal patient with fulvestrant upfront in the first and second line, whether it is for premenopausal patients as well. Mona Lisa 7 has shown clearly that these patients also have significant improvement in the overall survival. So there is a drug at least which has shown clear survival benefit and overall survival benefit in all the scenarios. With abemaciclib in combination with fulvestrant, there is data for improvement in the overall survival, while other data are pending for abemaciclib. Palbociclib Paloma 3, it has failed to show survival benefit, overall survival benefit, while data with the postmenopausal patient in combination with AI is pending. So we have overall survival data only for ribociclib in 3 situations which are possible in the real world. So Mona Lisa 2 is the largest first-line study in postmenopausal women that investigated ribociclib plus letrozole in first-line setting in postmenopausal patient. And also the trial reported significant PFS benefit, 16 versus 26 months. Updated report has found OS analysis as well, and we'll see the data shortly. The primary endpoint was progression-free survival for the study. Patients were randomized 1:1. Secondary endpoint were overall survival, overall response rate, clinical benefit rate, apart from safety and the quality of life. So, as we know, ribociclib given 3 weeks on, 1 week off, 600 milligram, and you can clearly see the ribociclib achieved longest reported overall survival. Sir has just discussed about 5-year survival data with CDK4/6, and here we can clearly see 5.3 years of median survival. So that is very, very important as against 4.3 years with hormonal therapy alone. So 12.5 months improvement in OS with around 1/4, that is 25% relative risk reduction in the risk of death. So that is again a very important point that needs to be taken, and also that needs to be considered and highlighted here. The overall survival benefit with ribociclib is increasing over time. What happens? We sometimes see the drug was working well, but with further follow-up, there is no difference in the survival, at least overall survival. But here we see the 4-year data, the difference was 5%. At 5-year data, the difference has improved to 8%. And 6-year data is also there. The difference improved to 12%. So definitely the drug is having persistent survival benefit, and that is increasing over time. So that is really, really very important. And the drug is not losing the survival benefit which was attained with the use of the drug. And also the most of the forest plot, you will see the drug is working well, and patients are having benefit in all the case scenarios, whether they have less metastasis, less than 3 or more than 3 metastasis. And definitely another important benchmark for our patients can be delay in time to first chemotherapy, and that is delayed by about a year, 38 months versus 50.6 months. So around a 1-year delay in time to initiation of chemotherapy can be attained with the use of ribociclib. With the, we can see the Mona Lisa 2 data, and also the depth of reduction in tumor size. And at 8 weeks, you can see it has reduced significantly in 32% patients, and in 17 patients it is on letrozole alone. So in other groups, the percentage change in tumor size is not as much, but depth of tumor reduction is highest at 8 weeks with the use of ribociclib. That means the drug acts pretty fast, and by 8 weeks you have a significant reduction in the tumor size what is found. And there is also some data to suggest that visceral crisis patients can be also be given ribociclib. Real world data is also available. Some Spanish data is also available. And Mona Lisa 2 is a large number of patients remained on treatment at the end of the study as well. So you can see treatment was ongoing in 10% of the patient despite a long follow-up of the data. If you see the majority of adverse effects, yes, no drug is without adverse effect. Neutropenia is there, but it is limited. Why it is not causing grade 3, grade 4 neutropenias as much? because the drug has more activity on CDK4, while CDK6 is expressed more in GI tract, so where it is causing diarrhea. That is the case with drugs which are having more selectivity for CDK6 will cause more amount of diarrhea, while this is not the case with ribociclib. Some amount of neutropenia will be there, but this is not turning into the febrile neutropenia. That is a point for our support. And also, you can see the data suggests that QTC prolongation is also in very small number of patients, and if it is there, it is not causing significant treatment delay, significant treatment arrest. As I was telling about the preferential limitation of CDK4 versus 6, it is for ribociclib 8 times preferential limitation of CDK4, and as CDK4 is more expressed on the breast cancer cells, the situation is seems to be favorable for ribociclib. Abemaciclib is causing preferential limitation of CDK4 by six times, while palbociclib is taken as the reference mark. So the safety concern with abema means diarrhea that occurs in a significant number of patients, and it was discussed in the last symposium as well. Diarrhea occurs in quite a significant number of patients, and palbociclib has more profound suppression of the neutrophils. It causes more amount of hematological toxicity, so might require dose reduction. So let's see a situation. Is ribociclib a rational first line choice? It is the only first line treatment, longer OS benefit, can be considered preferred treatment option in post-menopausal patient, and it has shown consistent OS benefit regardless of endocrine therapy partner, whether it is AI, whether it is fulvestrant, line of treatment first or second line, or it is pre-menopausal or post-menopausal. So definitely the longest reported median OS data, longest delay in time to chemotherapy, improvement in the quality of life, preservation of the quality of life, and established safety profile. That is possible with the drug ribociclib. With this, I will end here, and thank you for the patient listening. Thank you.